Welcome everyone. Let's talk about acute pancreatitis. Acute pancreatitis is sudden inflammation of the pancreas leading to acinar cell injury. So there will be activation of the pancreatic enzymes, inappropriate activation. These are example protease and lipase. What they do, they will do autodigestion of the pancreas. So they will destruct the pancreatic cells, acinar cell, by their enzymes. What are the causes of acute pancreatitis? This can be remembered by mnemonic called I get smashed. I get. I, idiopathic, then G stands for gallstone. This is the most common one, especially in female. E, ethanol, alcohol. This is more common in male. Then other causes like trauma, steroid, mumps, like cytomegalovirus or Epstein-Barr virus or hepatitis virus, autoimmune disease, scorpion venom. It means this one when a patient having scorpion sting, they receive scorpion venom. After 2 to 3 days, they will get severe abdominal pain. You have to suspect acute pancreatitis, but this is very rare. Hyperlipidemia, especially hypertriglyceridemia. So hypertriglyceridemia is the third most common cause. This is first, gallstone, ethanol. Hypertriglyceridemia is the third common cause. Then other causes like ERCP. The ERCP sometimes done as a diagnosis or treatment for pancreatitis, but sometimes it is the cause of the pancreatitis itself. Drugs, example, estrogen, azathioprine, thiazide diuretic, and also valproate. Maybe idiopathic or maybe pregnancy is rarely causing such a problem, but it's associated with increasing risk. Specific investigations for pancreatitis, the most important one is lipase. You send for amylase and lipase, but lipase is more sensitive. It is the preferred one. And what amount to increase? It should increase more than 3 times to be diagnostic, not just a mild increase. Amylase can also be helpful, but the amylase can be secreted in other glands, example salivary gland, or sometimes excreted from small intestine. So problems there may cause increase in the amount of amylase. So lipase is more specific. Ultrasound may be helpful to identify the gallstone, but to detect pancreatic swelling is difficult because it is retroperitoneal. It is very far away from the view of the probe, so that's why difficult to be seen. CT scan with contrast is not needed, is only needed when the patient when the doctor have uncertainty about diagnosis or to exclude any other problems that are there. So what is the management of acute pancreatitis? In the emergency department, the most important thing is fluid resuscitation. So you give painkiller and fluid resuscitation. Adequate fluid resuscitation is essential to prevent complications, and a urinary output, a target of more than 0.5 ml per kg per hour should be maintained. There was a randomized trial for patients with acute pancreatitis. They saw that patients with aggressive fluid resuscitation compared to moderate resuscitation have higher incidence of fluid overload, and there was no improvement in the clinical outcome. So that's why moderate fluid resuscitation might be enough for such patients. So you give 10 ml per kg for such patients, then 1.5 ml per kg per hour. Whether you give normal saline or ringer lactate, there are many debates, but you can give both of them. Although many authors, they prefer ringer lactate to avoid acidosis. Oxygen should be maintained above 95%. Analgesia and antiemetics like metoclopramide, analgesia, especially opiates, are important. Sometimes you give paracetamol ampoule. Even non-steroidal anti-inflammatory drugs can be given according to some guidelines. Antibiotics usually not indicated because it is an inflammation, it's not an infection. It is only indicated when there is a pancreatic necrosis, which can be seen on the CT scan if indicated, or when there is an infection elsewhere in the body. Example, a patient have a incidental UTI, pneumonia, cholangitis, cholecystitis, especially cholangitis might be associated with pancreatitis. Okay, nil by mouth, the aim is to rest the bowel and reduce pancreatic enzyme release, but nowadays they suggest just 1 day of nil by mouth. Surgical referral, so usually it is a medical problem. It can be just sometimes you need an ERCP for patients who have gallstone hepatitis, gallstone pancreatitis. But if a patient have gallstone pancreatitis, you have to do ERCP and sphincterectomy within the first 3 days of the admission. And ideally, if you are ideal, you have to do cholecystectomy in the same admission before discharge of the patient. Sometimes some doctors, they discharge the patient after 1 or 2 weeks. They ask the patient to come back again to do the surgery. What are the complications? You have local complications like pancreatic necrosis, pancreatic pseudocyst, pancreatic abscess, ascites, biliary tract obstruction, portal vein thrombosis, paralytic ileus, GI hemorrhage, and the more problematic one is the systemic complications. Example, hypocalcemia. Because of calcium deposition on the inflamed pancreas, there will be hypocalcemia. Hyperglycemia because of lack of insulin. DIC can occur, acute renal injury, and also acute respiratory distress syndrome, sepsis, multi-organ failure, and death. Sepsis is common in severe cases. There are some criteria for measurement of the risk of death of the patient. We have Ransom criteria and Glasgow prognostic criteria. They contain many numbers and many features, so it does not need you to know all of them. You can just have a mobile and search on these criteria just to know about them. You have Ransom criteria and Glasgow prognostic criteria. So, on summary, lipase is the most sensitive and specific blood test in suspected pancreatitis. The cause of pancreatitis can be remembered by I get smashed. Main management plan for acute pancreatitis is IV fluid, antiemetic, and pain management. Antibiotics have limited role in pancreatitis. Patients with gallstone pancreatitis should have an ERCP and within the 72 hours, and then ideally you do cholecystectomy in the same admission. And thank you.